Welcome to the Cincinnati Heart Failure Lecture Series. My name is Mahyar Poryahi. Today we'll discuss cardiogenic shock. It's one of multiple covering this subject. We'll discuss etiology and definitions, pathophysiology, clinical evaluation, and risk stratification. So what is cardiogenic shock? It is hypotension that leads to a severe impairment of forward flow, leading to end-organ hypoperfusion and hypoxia in setting of diminished cardiac output. Clinically, it's more of a hypotension refractory to volume resuscitation with direct features of end-organ hypoperfusion, such as acute kidney and liver injury. Acute myocardial infarction accounts for 81% of patients in cardiogenic shock. For us to understand cardiogenic shock, it's important to understand etiology. This data was published in 2019. It encompasses the Critical Care Cardiology Trials Network multi-hospital system, covering both cardiac and medical ICUs. They found that in their patients that were diagnosed with cardiogenic shock, ischemic accounted for a majority of the etiology. So what you see in part A is that etiology of shock, cardiogenic, and out of those, ischemic subtype made about 48%, 30% being acute MIs, and the others being 18% being ischemic but without an acute MI. 28% were in non-ischemic category. To continue this discussion, this is a great segue for a focus purely within heart failure. In 2022, this study examined the subtypes of heart failure-related cardiogenic shock. They decided to utilize SCAI shock classification, which we'll discuss a little bit later during this PowerPoint, or Society for Cardiovascular Angiography and Intervention staging. They assessed patients that required acute mechanical circulatory support and examined out of those how many were acute on chronic heart failures as opposed to de novo. They subtyped their de novo patients, as can be seen in section B. But what I wanted to focus on is the overall elevated in-hospital mortality that can be seen throughout all groups, however, more exaggerated within the de novo group. So before delving further into cardiogenic shock, it's important to understand contributing factors to worsening heart failure. What are some of those important factors? Acute myocardial ischemia, uncontrolled hypertension, arrhythmias, medication non-adherence, or negative inotropic medications, alcohol use, anemia, worsening renal function, hyper or hypothyroidism, acute infections, and other acute cardiovascular diagnoses. Here are some of the very pivotal trials that led us form our basis of definition that we are going to discuss. And what I want you to look at and what I want you to assess is basically twofold. It is on one side, a decrease in systolic blood pressure below 90, and on the other, an end organ dysfunction, which is related to a cardiovascular cause. So if you look at some of the trials, they use different parameters to assess an organ perfusion or an organ dysfunction. Whether looking at a renal, other labs, including lactate, you can see a variety of different parameters that are utilized. That's usually in setting of some sort of either clinical or other assessment for cardiovascular cause, whether that is a decreased ejection fraction, pulmonary congestion, a reduced index. So what is the pathophysiology? Now this figure, in my mind, is very informative. It's looking at the acute MI, but I think this is a great way to try to understand the basics. So you have an occlusion of an epicardial coronary artery, which leads to myocardial ischemia. This leads to a decreased cardiac contractile mass, decreasing the ventricular function or ejection fraction, which then leads to a sympathetic and neurohormonal activations. So an acute increase in your catecholamines, an acute increase in your vascular resistance or vasoconstriction, activation of the renin-angiotensin-aldosterone cascade to increase the salt and water retention in an attempt to maintain blood pressure, which then further stresses an already weakened heart by increasing pulmonary congestion, leading to hypoxemia, which then worsens your ischemia. And this then becomes a downward whirlwind with worsening and organ dysfunction and further systemic inflammatory responses. We slightly touched on this subject, but what is sky shock classification and why should we use it? As I'll go through this lecture, hopefully we all can understand how essential it is to assess cardiogenic shock and to understand the progression or deterioration of this disease. Worsening shock staging is directly correlated with worse morbidity and worse mortality. So, how do we define the staging? As you can see in Sky Shock Stage A, it's a placeholder. It's not currently experiencing signs or symptoms of cardiogenic shock, but is at risk. Who are these patients? Usually these account for most of your acute decompensated heart failure patients that are seen in the hospital. B, clinical evidence of hemodynamic instability or hypoperfusion without a direct end organ dysfunction. As C and D and E progress, you start seeing a more exaggerated end organ dysfunction with inability to control with inotropes and or acute requirement for temporary mechanical circulatory support devices. Another good older profile to understand is INTERMACS, which is an interagency registry for mechanically assisted circulatory support. This became an essential definition and terminology during the earlier VAD era. INTERMACS 1 defines a crashing and burning patient, while INTERMACS 7 is a placeholder with someone NYHA class 2 or 3 with no recurrent or recent unstable fluid balance. And as you can see, as you progress from 6 to 1, you have worsening of congestion with other morbidities that account for it. So you start with walking wounded to housebound to frequent flyer to dependent stability to sliding on inotropes. Now, this chart is excellent because it helps put all of these patients in perspective. While we didn't cover NYHA classification, it would be covered in another one of our lectures. So when you look at the pre-shock, these are patients with stage C, possibly D, NYHA coming in at 3B to 4, within an INTERMACS somewhere in the 4 and 5 ranges, and SkyShock A. As things progress, you can see the progression of both SkyShock and INTERMACS. While I really like the ACC and NYHA definitions from both of a clinical and symptomatic profile, they do not serve well in subtyping and analyzing patients in shock. As you can see, all of them fall somewhere within the NYHA class 4 category and somewhere in the ACC stage C and D, but that doesn't really further subdivide these patients and their risk profiles. So why are we discussing SkyShock classification? SkyShock is important for us to assess patients. The earlier assessment, the earlier discussion, the earlier optimization can lead to better survival. And as you can see, as patients go down from A to E, their hospital mortality directly increases, where stage E accounts for the highest risk of both ICU and hospital mortality. That should make sense because these are the patients that have the worst profiles and they're becoming refractory to all treatments. What else is important to understand? It's important to understand that age group, when you subtype the SkyShock groups, also plays a factor to overall survival. As can be seen, patients greater than age of 80 do much worse than their equivalent SkyShock stage counterparts in the other age groups. I'll let you look at this slide or these two figures. I hope thus far we all feel comfortable on what is cardiogenic shock, what accounts for different subtypes of cardiogenic shock, and how to classify it. As to why it's important on how to classify it, again, it's because the earlier assessment, earlier categorization, earlier intervention leads to the better outcomes. All right, so how do we start our assessment? How do we do the initial evaluation? We look at signs and symptoms, assessing levels of congestion, urine output, hypotension or hypoperfusion, with the assistance of further imaging lab and other modalities. And then we triage. Whether that is to a higher level of care, if we don't deal with these patient subtypes as often, versus to a cardiac catheterization laboratory, because in setting of an acute MI or worsening shock, or needing the data to further assess the patient, such as a right heart cath, versus cardiovascular ICU admissions. This publication subtypes some of the worst factors we know about shock. What am I talking about? What do we assess in cardiogenic shock to assess worsening of shock? We utilize lactate, which is a sign of an organ dysfunction and hypoperfusion. We look at an acute renal failure and then an elevated or worsening liver functions. So what is this then looking at? It's looking at the cumulative survival with worsening data. As you can see, just looking at and assessing these patients, worsening lactate, worsening renal function, and increasing liver dysfunction leads to worsening survival. Like with everything else in medicine, there is definitely a social status disparity. And this is also important for us to understand and have an awareness of, whether to understand just medicine or social determinants of health or biases that might play a factor in all of this. There's an increased incidence of cardiogenic shock among patients who are socioeconomically disadvantaged. They have a reduced probability of a 30-day survival, and they're less likely to undergo invasive cardiac procedures. So what about racial disparities? This study examined acute myocardial infarction, cardiogenic shock, as it related to in-hospital mortality and revascularization. What I want you to focus on is that in this study, which does match a lot of our awareness as well in the greater US population, Hispanic and African American patient subtypes had an overall more exaggerated in-hospital mortality as opposed to the rest of their counterparts. Also, revascularizations, there were some disparity or discrepancy among some of the different racial groups as seen. This part of our lecture is coming to an end. It's part of a larger series. I hope at this point you have a better understanding of what is cardiogenic shock, what is its etiology, how to assess it and classify it, and why it is important to assess this patient earlier on. Thank you for your time. Feel free to send me any questions that you might have. Take care.